Welcome to SIIMcast, a podcast brought to you by the Society for Imaging Informatics in Medicine.
Welcome to part 2 of our recording with Dr. Steve Horii, or as he's known as Dr. DICOM. As I mentioned in the last intro, if you've known him from the annual meeting, he always has very insightful questions that always makes you think about things in a different way. Please enjoy the rest of the conversation. One question I have is, like, you talked about like how you negotiated with the Japanese on making things work with encryption, this and that. Like, I've always wanted to know, like, when you create a standard, how did you guys have the forethought to have the flexibility to do the things that we need to do, but still be rigid enough to actually be a standard and stand up? Because we're trying to do all these things nowadays and trying to thread that needle and to look at what you guys did and like, how do they have the forethought so that they've built this in the way that they could do this later on? And it just blows my mind. Like, because you guys were just making it up as you went along because you hadn't done anything like this before, but clearly you had built it in a way that you could do this. So can you talk a little bit about that, please?
Well, we had some ideas from other standards. Notably, there was a standard used by nuclear medicine for putting stuff on tape. And one of the things they did is they had what's called a key value pair for data elements. So you had a key, is what the element is, and its value, it's what it contains. One of the differences, their keys were in human readable text. DICOM went with a numeric tag, right? You see the group of two numbers, like 0010, 0010. Yeah, that's what we used for keys, but the idea was the same. And then the tag, we made it, I think the Nuke Med standard was the same thing, and they published that standard. So we looked at it and said, you know, this is a good idea, this key value pair, because it makes it a lot easier to figure out what you're coding. Yeah. And then a variable length field, so you could accommodate fairly long things. I mean, there are some restrictions to that, but the element tells you the key and the length and the value. So you know how big a thing to expect. Although I think there's a way you can say it's a fixed field length or something, but that's basically that you have to deal with that in HL7. Their field lengths are fixed. But that's one of the things that we thought of is what are other standards people doing? And nuclear medicine community, that I think it was AAPM. I think that was a standard. I don't know if it still is because of mag tape, but the AAPM magnetic tape standard was one we looked at. We looked at Landsat. We looked at some of the broadcast stuff, but those guys were encoding audio and video. You know, it wasn't like discrete pixel data, and there was no digital TV at the time. But yeah, as much as we could, we looked at what other standards had done. The idea of the information model, I said that came from the AT&T folks, and it was a great way. That made the transition from ACR and EMA to DICOM, because although we had all the key value paired elements in ACR and EMA, we didn't have a great way of organizing those around, you know, what the image was. You know, it's like, okay, this is a description of all the things you need for CT study, so that becomes the CT object. The other thing we did is we looked at, well, you have the objects, the images, and then you have, what do you do with them, right? So we have the data and then the what you do with the data, and that's sort of how DICOM is structured, right? You have the what's called the SOP class, the service object pair. So service, what do you want to do? Do you want to store it? You want to print it? You know, what do you want to do with it? Display it? Service object pair, and the object contains all of the data elements you need. The service says, this is what I want to do with that. And that is the fundamental unit in DICOM, is the SOP, is the service object pair. Because for any piece of information that tells you what you want to do with it. But that allows for expandability, right? You add services as you need them. You know, if you need a web-based service, well, you can use a web-based access method. You can write some code for that. And then at attributes, you can add what you need. You know, like the cardiologist had stuff that we didn't have in there because they wanted like EKG data, right? Well, how do you code waveforms? They're voltage versus time or something. And so how do you encode those? We figured out a way to do that. But it was all, we could all doable within the data structure we had. And I don't think any of us were data scientists. We just thought that this made sense. Yeah. You know, I think a data scientist would probably say, well, you could do something else, but, you know, it was a way to accomplish what we wanted. And we found that it was flexible. The other thing that helped a lot was this whole idea of making group that did DICOM expandable. So we got domain experts, right? And then the DICOM stalwarts, those engineers who worked out all this stuff, they had all the basis knowledge for how to take what the domain experts said, yeah, I've got this image in pathology. I need color. I need a lot of resolution. I need this, stride scanner. Right. They need precision color, right? We have grayscale stuff. That was the one part of the standard that's not to communicate. It's to allow monitors to look the same no matter what digital input you have. That's the DICOM display standard.
Right.
But that idea came from industry. They do the same sort of thing with broadcast stuff. You want your TV images to look good and no matter whose TV you're looking at. So they have these monitors that they calibrate monitors like that, the color calibrations and stuff. So we looked at that. Now the color mapping thing is a little more complicated. There are standards for it though, so just use them. So cardiology has their own domain. Gastroenterology, they wanted a lot of cine stuff. Dermatologists who needed high fidelity color and stuff for skin lesions. Then how do you identify where you took the image? And the thing is, where was this taken? And it's not a whole body thing. If you're something on the arm, where is it? So we had an anatomy locator, sort of, but they needed a little finer detail in there. So those kinds of things, that was the idea that I think was really useful for a standards committee, is having domain experts who know what the standard's going to be used for, telling you what they need, and then the techie guys saying, hey, this is how we implement what this group needs. So that's one of the ways we did it. That and the thing like languages and stuff. We still run into challenges.
Sure.
New imaging things come up and it's like, well, we've never done that before. And then the information model idea that you could break things down, in the IHE idea that you could break things down into actors and the stuff they're acting on.
Right.
And those are fairly flexible ideas, right? If you need a new actor, you get some new way of doing something or a new kind of information, you can make a profile that says, okay, this is how we handle this new situation. That's the kind of thing we think about when, what are you going to handle AI? Well, do you have a new actor? Is it the AI, the AI model that's doing your processing? And then what do you do with what comes out of that? You've got an AI, is it segmentation? Does it tell you like the coordinates of the area of interest, or how does it work? Or does it superimpose it on something? Those sorts of things is sort of we're thinking about. If you're doing diagnosis, okay, it'll tell you what the answer is, just like what the radiologist report is. But then we want those quality assurance checks. So you're going to look at the, what do they look at now? They look at the various indices, Jacquard index and DICE coefficients and the like. But then there's also, the heat maps. What is the AI looking at? How do you encode that? Well, it's basically like an overlay on an image. We know how to do that in DICOM. So as these things come up, you're right, though. That's one of the things. It's not that we put some thought into it, but I think a lot of us were thinking about what are the potential use cases and could we accommodate those with the structure that we have? And, big data is another challenge because it gets to be beyond the limit in counting things. We can't get that big. And are we designed to handle something data that large? And that's another challenge right now. Because right now the idea is you break it down into manageable pieces. But if you want your AI model to have access to a huge database, like if they ever finish it, some huge database of cases, how do you manage that?
Right.
Well, probably take it in chunks. But then how do you train? How do you train on a big data set like that? That's the AI people need to figure that out.
Yeah.
We're figuring out, what do you do with the results? How do you represent them in some format that's interchangeable?
Yeah.
It's like we didn't think about it a whole lot, but then cloud storage for distributing patient images came around.
Yeah.
Companies are doing that. We said, what do we need to do in DICOM to make that feasible? Say, well, the images are DICOM. That's not the hard part. They have to be concerned with the encryption keys, because it's public key encryption is what they use. And of course, there's standards for that. So that said, we don't really have to support that part, right? We have to support the image part. The vendors of those systems have to support how they handle the encryption and access. So, and we do have a security group that looks at encryption and stuff, but we didn't have to worry about the details of how a particular vendor is going to do something. That's something interesting. I've just run across this, and I haven't written the proposal yet, but I'm thinking about looking at AI development in other areas. And I found one recently from the autonomous vehicle people that the Underwriters Laboratory, UL, they got the little stickers on all your plug. They have a standard guideline for developing autonomous vehicle AI. And it's really interesting because they don't go into detail like you need this sensor, but they do have things like, here's a list of questions you might want to make sure you can answer. We think about that and said, well, there's a lot of similarities between an autonomous vehicle and what we do. You have false positives. Okay. It makes a stop because it thinks a tree is a person, right? Or a false negative. In fact, it turned out that some of the sensors that are used in these vehicles to detect people are not sensitive to that yellow-green color that construction people, it doesn't recognize that as a person because it doesn't know that color. So you got to train on it. They can train on it. But, that was one of the things they found out I don't know if they found out the hard way, but I hope not. I know that one person was killed because the application didn't recognize a person on a bicycle. I think it was someone walking a bicycle as a person.
Really?
Yep. So that's a little bit of a problem. And then there's that, the potential for hacking an AI in a car. But so there's that sort of thing. So I want to look at that standard and know that what they proposed is because some of those ideas may cross over. I also need to go look at some of the other organizations I sort of keep track on. And I'm interested in navigation and guidance stuff. It's one of the crazy hobbies I have. But I just want to know if the Institute for Navigation, because, we have AI sort of tools in aircraft now, which just cause problems, right?
Yes.
The autopilot kicks on and it does things and the pilot doesn't realize that the autopilot's on. Right. Like it's trying to make you pull the plane up and you're trying to make it descend or vice versa. And, your panic of the cockpit's doing funny things. You don't realize that the autopilot's still on. And then there was that, because it turned out that one of the autopilot switch things was not taught in the simulators. So the pilots didn't know that this could happen. It could lock them out from controlling the plane.
Right.
Yeah.
So
That was the recent Boeing
right.
Air Max one.
Yeah.
So that's a problem. But that's one of those things that I have concerns about. The whole AI idea, that my concern is, should we have a trust index? And if so, what goes into that? And that's the kind of thing that other industries may be looking at as they're talking about AI. If you've got a robot in a factory that has to interact with people, there's a lot of things it has to worry about. Right? Is it going to crash into somebody? I think one of the first deaths from an automated, it wasn't an AI, it was just a stacking thing. It was like a mobile forklift and it could pick up a crate and then stick it on a shelf. Well, the problem is it didn't detect somebody because at the time I don't think they were worried about it. And they were said, you just assume the aisle is clear, go down and pick up the crate. And what it did is it pushed the crate into a guy standing between it and the wall. So this was before AI. Even the idea that there's the problem, I think, in general, that I have some concerns about. And one is the rare event, right, that can cause a catastrophe.
Right.
I mean, think about all of nuclear power incidents. A lot of them have been like Fukushima, right? Fukushima could have survived the tidal wave and could have survived the earthquake individually, but not together. And I have a feeling that's why they shut down the S9E04 reactor. But you ever been driven by it? It's right on the water between LA and San Diego.
No, I haven't.
Oh yeah, you can drive right by it on 5. It's sitting out there for all to see. And well, it's been shut down, but you can see all the power cables coming out. But they closed it down. I don't know whether it's just, out of date and not producing enough power for what it does. But I thought, it has the same potential, Fukushima.
Fire, basically.
Yeah, right. It's you get earthquakes in California, you get tidal waves across the Pacific. So yeah, it's a concern. The other one is, I think about it as the radiologist with unusual memory. Because I've had colleagues come up and I'm looking at something and I ask one of the guys, what do you think about this? I see this thing on CT and I'll just right up top and said, pull up so-and-so from 5 years ago. And you pull up the case and that's the same finding. And it's like, how do people remember this stuff? And what does that mean can an AI do that?
Yeah.
This is like some memory that goes way back and it just remembers that. And the other thing is the rare condition, the old saw about if your hoof beats, don't look for a zebra, look for a horse. So that's the thing is the problem is even with humans, how do you account for the rare case? And if your training set doesn't have any of them, is it ever going to recognize one? That's the problem is that rare stuff is rare. So the prevalence is rare. It kind of can screw up your statistics on how well it's doing.
Or bias of see a rare case. So now suddenly it's in your mind. So you might hedge towards that, even though statistically you should be on to common things again.
Well, that's like, I work in this fetal diagnostic unit at CHOP, and we see really rare stuff.
Yeah.
We've seen cases that they said this is a case report, needs to get published because it's like 1 in a million cases. And the problem is I see all these patients and the fetuses all have something wrong with them. And it's like, why would anyone get pregnant? It's like, look at these bad things again. It sort of skews your whole idea of how dangerous pregnancy can be. Then you have to keep reminding yourself, no, most fetuses don't have this stuff. We're concentrating. It's true of any specialty, any medical thing is, if you're a specialist in thyroid disease, you're going to start to bias yourself toward, there's a lot of people with thyroid disease. Although, isn't a nurse picked up a thyroid nodule on someone on TV? I think so. I think it was a nurse watching, it was a show where they redid houses. It was a husband and wife couple.
Oh, okay.
And they noticed he had a lump on his neck and they called and said, you ought to get this guy to see it. I got thyroid cancer. So yeah, someone picked that up on TV. That's the thing. Some of the stuff that humans do is tough to account for. I had a resident one day and I was walking by and he said, you take a look at this. And he said, CT scan on a young guy. And I said, it looks like cirrhosis. And he said, yeah, but we looked at his history. He's not an alcoholic. He'd never had hepatitis. He's negative for all the liver diseases, but other than he's got cirrhosis. So why did he have cirrhosis? And I said, how old is this guy? And they said, oh, he's about 28 with cirrhosis. They said, did he have congenital heart disease? And the resident looks and he said, yeah, he did. He said, hyperplastic left heart. I said, did he have a thing called the Fontan procedure to correct? Said, yes, he did. Said, okay, that's why he has cirrhosis. That procedure increases your hepatic venous pressure and eventually damages your liver.
Right.
So he said, how did you remember this? And I see these cases all the time at CHOP. It's like, oh yeah, that's because they have to manage these kids later on.
Right.
You do a Fontan and it fixes them. But so that's the kind of thing I'm not sure that AIs can do at this point because you're correlating multiple things. It's not just the history, but it's history with a rare condition. So that makes it a little difficult. I'm not saying AIs can't do it, but how do you train them to do it?
Yeah, that's a difficulty between like the specific versus the generalized, right? Like we are generalized, and then you have an AI is like trained for osteomyelitis, right? It can't be, so yes, but it will not be able to pick up on all these other random things that you might have to deal with that we see, like HPOA, right? So you get this periosteal reaction on the shins, and you're like, you see it on nukes, you see it on plain film, like, let's go check the lungs. Hey, yes, they have some pulmonary disease, right? But if it's not trained, if it doesn't know these associations,
right?
But we're taught all those things to kind of look at it, but the computer may not. And then to your point of like, I've seen all these different things. Like when I was in med school, I'd just taken my upper limb anatomy class, and my father, like, he spent a year in anatomy and physiology. So he walks in, he's like, oh yeah, that's this. So I'm like, you were in med school 30 some odd years ago, and you remember your arm anatomy better than I do when I just took the test last week. And he's an ENT surgeon. So your memory of these experiences and everything else, like, yeah, how would AI be able to capture that? And not to say that the FDA process is incorrect. They're doing things for a certain reason, but the model can't evolve without a new set of clearance, et cetera. So we evolve. How are we going to be able to incorporate that is a great question.
Right. And can you train if there's any probabilistic stuff in there, if you're training on, because those cases like that tend to be things that are rare, unusual that we remember, right? You might remember the case of the conference where they put up a chest x-ray and, you realize, well, the label's over there, this is a situs inversus case, right? That used to be the favorite trick, right? The attending would hand you the x-ray instead of putting it up. Right. And so you put it up the usual way and okay, look for the marker. Oh, the right marker is where the cardiac apexes. That was a trick that they would pull on you. But that's the kind of thing is you remember these unique events or these rare events. And how do you train for that?
Yeah.
And how do you train for deduction? Right? So I've got this complex of things across multiple sources of information. How do I correlate those to come up with an answer? And, I think if you've got the right training mechanism, you can probably do that. But right now, I'm not sure that the association stuff is quite there yet with AI.
Like, how do you teach AI to do a differential?
Right. Although there was a paper that came out, it was pretty interesting. It looked at the radiologist report and generated a differential diagnosis. And in the paper, in their test study, it actually produced a correct differential diagnosis that the radiologist missed.
Wow. Yeah.
That's pretty good.
Yeah.
So now, how often would it miss one that the radiologist called that was correct? But on that one case, it called one that the radiologist didn't include. Again, because it was an unusual differential diagnosis, but the AI got it. So that's the kind of stuff that's drawn me to informatics. The good thing about it is because the technology is evolving, you'll always have something to keep you interested in, right? Like now it's AI, but for a while it was, digital imaging and digital techniques came out. It's like, how does MR work? And I admit to being a little bit puzzled by AI-assisted reconstruction.
Yeah.
The first time I saw that, I said, how are they breaking the laws of physics?
Yeah.
Because they showed the dose and they showed these images that really didn't look like low dose CTs. But how are they doing that? You got quantum detection there. Why isn't it more noisy? Well, they were doing something. And my concern at the time was, are they telling the AI to make it look like a better image?
Oh, okay.
Or is it actual processing that does it?
Sure.
Noise reduction.
They feed it a bunch of normals,
Right.
high dose. And then when you feed it a low dose, you say, make it
look
this
like that.
way,
Right.
instead of actually, okay.
But I think it's much more sophisticated. I think they're actually looking at the noise profiles and stuff and basing on that. But yes, as I say, that's the nice thing. You'll never not have things you're curious about.
Right.
There's always something to be interested in. There's always and they're right, as it is now, you're always getting more than you can accumulate. It's like, oh, okay, I'm trying to learn Python now. I can write a little code, but I'm certainly no Python expert. I can still write code in Fortran, but who uses Fortran? Old guys.
Do you find that you've become more wary or paranoid about, so for example, like we're all talking about AI, it's great things, but mammal cat, right? We all know like how bad it is. So you don't trust, like, you turn cat on when you're looking at a mammal. It's like, I don't trust what the marks are. Maybe I'll take a look a little bit closer, but a lot of times it's labeling vessels. It's labeling segmental or completely benign calcification.
Right.
It's flagging those. So do you feel like paranoid or numb to like, whatever I don't know. We'll see what it says. Maybe. What are your thoughts on some of those kind of things going forward?
The concerns I have are, as I said, how do you build a trust index? How do you know when you can say, okay, I believe what this AI says? And I know that there's people working on the counterfactuals idea that you purposely give it something, to see how far you can push it. And you look at what breaks it and what breaks your algorithm. And when it breaks, you say, okay, let's go back and look and see what's going on in there, why it broke, why this counterfactual broke it. And then you could figure out, well, maybe there's a better way to handle these internal layers. That's one idea I've seen. And the other is the problem with heat maps is you sometimes get what is that really telling you? Is it good enough? It's probably not. It gives you some idea of what the thing is concentrating on, but is that all it's doing?
Sure.
The other thing I worry about is, do we get to really the idea that we have AI good enough for fully autonomous operation, take human out of the loop.
Right.
But if you think about it, we've avoided 2 nuclear conflicts because a person was in the loop. There was a Russian guy who saw the alert and he said, I don't think this is really an attack, because if he sets the alarm, the Soviets are going to launch an attack against the U.S. and it would have been a fake. So, and I think there was a time when the U.S., one of the guys when they first activated the NORAD, the radar site, right away, they turned it on. They were getting a signal back. So we got something coming over the horizon. It was the moon. They were bouncing radar signals off the moon.
Wow.
But for the second there, they thought, oh my God, we turned the thing on and we're getting attacked already.
Yeah.
There are people in the loop. That's why, fully autonomous vehicles, a little concerned about those right now.
Yeah.
And even worse are the autonomous military stuff, like autonomous soldiers that can go out and kill people without a human in the loop. A false positive there is really bad. And a false negative, well, you might lose a robot, but that's the kind of thing that I don't think we're ready for full autonomous AI yet, at least not for the kinds of applications where the risks are high. For some things, maybe so.
Yeah.
You get a pin setter in a bowling lane. Yeah,
Sure.
I'm sure that an autonomous AI could do that. But, do we really want to say that, you're absolutely safe taking an autonomously driven taxi? Because there's two efforts going on, right? There's the one out of Tesla people, and then there's another one that's another company, and theirs is a much more elaborate sensor system.
Waymo.
Yeah, I think it's maybe Waymo. And they're testing it pretty heavily too. They've got a test track, and that's, I think, the kind of thing we need to do is test. And one of the things I always ask people who do segmentation is, how do you know your algorithm is not better than a human? Right? If your human is a gold standard, how do you know your segmentation is not better? Right? You'll get a difference. And what does that mean? So, and some people have fixed that. They make phantoms.
Sure.
So you know exactly what it is you're trying to segment, and then you can see, is the person doing better than the algorithm or vice versa. But then you need really good anthropomorphic phantoms, and that can be tough. I know that there's some digital breast ones out there that people are using that seem to be pretty good. So that's one thing, is how do we get tests that are strict enough to make us confident?
Yeah.
That's the thing, is how do we know? What's the trust index?
Sure.
Can you build a trust index? And it's probably going to be different for different AI applications. So, but I think we need that before we just say, okay, yeah, Hinton was right and we should stop training radiologists. I don't think there's any thought of having a robotic interventional radiologist at this point. And people get the wrong idea about robotic surgery. They get this vision of a robot. No, but if you've sat at one of those consoles, it's pretty neat, actually. The surgeons let me sit at one, and you get this incredible view. If you have a slight tremor, it can take that out.
Right.
You can stop the heart beating, electronically. That must be a strange view for a surgeon, though, to look in at the heart's not moving. But
hear the beep on the anesthesia machine,
right.
So you know the patient there.
And the thing about surgery, too, is a lot of times in surgery, it's unexpected stuff.
Yeah.
And you'll get in there and realize there's an aberrant artery or something, and okay, I can't just cut this. I got to go around and find something else. And that's tough for an AI to do.
Yes, you can't do cookbook.
No.
The rules-based gets you only so far.
Yep.
Right, protocols, right?
Yep. The same thing for flying aircraft. All kinds of crazy things could happen. Or running nuclear reactors. You can get the rare event, or that people think, oh, these things are never going to happen at the same time, and then they do.
People, talk about pilot track lists a lot, right? And they're great. But at the bottom of the list, it doesn't say, fly the damn plane, you idiot, right? It's assumed that you're going to your brain and go to your training on how to fly. And these are the steps you don't want to miss.
Right.
It's not the end all be all of what you have to do.
No. And in fact, there's a critique about checklists because it can make you not think about the stuff that, checklist has what you should be checking, but there's the other stuff that maybe you ought to look at anyway. Like, what was it? They made that one mistake about they dipped the fuel to look at the amount of fuel. And the guy looks at the number and he says, okay, well, it was like metric instead of imperial or something. So the amount of fuel was different from what they thought they had. So that kind of stuff. The checklist says check the fuel level.
Yeah.
We did.
It's very like with template reports. So when team training residents, I'm like, well, are you also looking at these other things? But they're not thinking about that because it's not on the template.
Right.
So they don't think like, no, still have to look at these other subtle things. So the problem becomes like, do you make a super detailed template or not? Because then you just have all these structures that most people don't care about,
right,
or need to know about. But these are the structures we still need to look at and make sure they're okay. Especially when you're trying to teach somebody, like an attending will have automatically looked at it because we're trained to do that.
Right.
It becomes almost a crutch. Like I remember talking to one resident, I was like, all right, tell me what you're going to say in your report for a procedure that we just did. He's like, oh, I'll just grab a template. I'm like, if you're on the stand and you have to say like, oh, let me look at my report to just for generic, like, how do you normally do this procedure? Not the specifics, right? And you can't even say, this is how I normally do something. How is that going to look?
right? That you're not following the standard of practice. That's what it says.
And I was like, yeah, I walk in, I get my consent. In general, I get consent, I clean off, like those normal steps. And of course, you can refer specifics to your report, but if you can't just list off the normal steps, like, how does that look? Like, does this guy know what they're doing? Do they not? Right?
Well, I'm sure that you guys probably were taught in your residency that our attendings always just say, look at all four corners of the image. In fact, they taught us, and I have several of them said, look, if you see something right away, put up a chest x-ray, you see an ammonia, said, come back to that later. Look at the other stuff first, because you get the satisfaction of search problem.
Yeah.
You say, okay, patient's got a cough and a fever, I got a pneumonia, and forgetting to see the lung nodule on the apex. So that's the kind of thing that we were taught. How do you teach an AI that? You're going to teach it to look at the whole image, but, can you be biased by the history you got?
Right. And also it's, the PE detector. So it's looking for PE. It's not looking for lung nodule. You need the separate lung nodule. So it's a thin slicing through every single thing in medicine. You have to have a specific algorithm for each of these things. So it gets crazy. Like, how are you going to run all of them at once?
That's why I thought one of the most interesting ideas in some of the screening AI stuff is to just be binary, normal, abnormal. Right? Because that way, the abnormal ones the radiologists are going to look at in some detail. The normal ones, if it's good enough and doesn't miss stuff, that's pretty good because it can save you a whole mess of time.
Right.
And I know there are places that have done that. They're trying that.
And the question really becomes with something like that, it's normal variant. Part of the reason why radiology residency is so long is learning what the variance in normal is. Pathology in general tend to see it pretty quick because this does not look right. But the variance of knowing, like, no, that's a normal variant. And like, how do you digitize Keats, right? And like the variance in like fetal anatomy and things like that, what's actually worrisome, what not. And it's hard sometimes.
Right.
But just those even simple things.
Yeah, there's lots of challenges because, years ago, it was Halkendall, he's the perception guy, and Liz Krupinski, who's done a lot of perception stuff. And one of the things they always say is, how do you figure out what you're doing? How do we figure out what's going on in your head to come up with this answers? We don't really have an answer to that. I mean, we don't know. We know that MRI, you can light up parts of the brain depending on what you're doing, but what's going on down at a lower level?
Sure.
How do you emulate that, right? Electronically, if you don't fundamentally know what's going on, it's a challenge because I think we're constantly learning stuff too. Like I talked to this one physiologist I was working with. She was doing studies on eye tracking, and she told me something I never realized before, that if you're following something moving with your eye for part of this tracking, you move your eye. You get to a certain point and then you start to turn your head. Yeah, your cerebellum does that.
Yep. Right. Your eye saccades, so they'll jump. Unless you're slow tracking an object, when you scan a room, your eye will look and then your brain turns off. The eye moves to the next spot and then it turns back on. So you're actually getting like multiple pieces and then your brain stitches it all together. I remember this when I was in engineering. I'm like, oh my God. So otherwise your brain would like freak out because it's through the jumps. It like doesn't know what to do with that information.
Well, that's like the stop clock illusion.
Yeah.
You ever seen that? It's not secondhand and you look and it looks like it's not running.
Yeah.
And that's your brain because it's like, wait a minute, there's a change there and it can't keep up with it. So yeah, that's a strange illusion. The first time you see it, it's like, my watch stopped.
And then some of the things you're talking about, like thinking like, yes, we can do fMRI, but at the lower levels. So when you're teaching residents, like the communication of like, this is what these words mean to me. What do they mean to you? Like if I say yellow, I may have one color yellow in my head. You may have a different color of yellow in your head, right? And then of course the associations, like kids may think yellow, sun, warm, play, right? But someone else will have different associations. So now when you start describing like, well, this is like a severe foraminal stenosis, right? So, okay, well, what does that mean to you? Does that mean this is a surgical lesion or not? When you're in your report, are you communicating so that the person on the other end says, okay, severe means this is a surgical lesion or it's severe? Where do you start breaking down some of these communication level things too? So now the question is like, when we have these AI looking at it and they put out this report, they do it like, where are they along that kind of thing? How are we going to be ingesting that and thinking about it and like how it's going to change things? I don't know.
Well, isn't that the part of the idea behind like TIRADS and PIRADS and BIRADS? Is it, you sort of break this down into things that would, I guess that each of those has certain consequences, right? You take certain actions based on what that code is. And so that's the part of the idea behind that, is you try to make it more specific.
Sure.
Rather than saying, yeah, you got a bad case of something. It's like, okay, is it going to kill me, or is it just going to make me lie down for a few days?
Right.
Yeah, that's one of the things, that the context is important,
Right.
and having some sort of quantifiable thing. And the problem, of course, is, yeah, we have these classification, these ranking schemes, but how good are they in the long run?
Right.
That's where you need outcome stuff. And it gets fed back to us, right? Like we keep calling a BIRAD something, and it turns out the patient is perfectly fine and has a survival rate of 10 years later, still disease free. Well, then it probably wasn't a BIRADS 5 or something. So it's one of those things where you may need long-term data to help your AIs get the stuff right. And that's again, it can be time consuming, obviously, to do that. What's the study that they're running up in Northeast? They've been following these people for years. They're looking at like high blood pressure and stuff. Yeah, the Framingham study. They're still going at that, right? Yeah.
As far as I know, yeah.
So that, and data that comes out of that ought to be pretty interesting.
Yep. I think they publish every few years,
Yeah.
like updates, basically.
It'd be really interesting now that we have the genomics and stuff to take a look at, are there differences in these groups? So that's the other thing that's sort of gotten interesting, is now we have another whole data source that can influence what we're talking about. As I said, you do informatics, you're never going to be bored. That's part of why I found it so exciting, is like, you're right on the bleeding edge of stuff. It's no question about it. You don't have to be an adrenaline junkie, but it really, if you're curious and you're stimulated by being curious, it's a great thing to do. And I think there's no question that that's what helped drive me along the path that I took, being interested in stuff. So anyway, that's sort of how I got to where I am, and still coming to this meeting because I want to keep up with what's going on. And besides, meeting old friends and stuff. But yeah, I get to talk to the DICOM guys because I don't go to all the committee meetings anymore. I get the ballots to vote on and stuff, but I don't have to go to all the meetings all the time, which is good for me. But so I don't keep up quite as much with all the current stuff. It's like, it just advances in radiology. Like I keep up with the stuff in fetal imaging, but I don't keep up with the stuff so much in general abdominal imaging, unless some fascinating article comes out, or ones that could directly affect me. One of the interesting ones is, you can do this exercise with your fingers to improve your memory. It's like, what? I got to find out more about that.
Yep.
Because, I'll forget to, the usual thing. It's like, I walk into it's like, what did I come to this room for? And eventually I'll remember it, but it's like, I came here for something. Right. So, but yeah, I talked to a couple of neurology people about it. And they said, if you forget to remember a name or something, if you eventually get it back, that's okay.
Right.
It's if you can never get it back, that's bad. So he said, don't worry about it. Yeah, you forget why you came into a room. Yeah, we all do that.
Well, we could probably just keep talking, but thank you so much, Steve. Like, this is great to hear your story and some of the history on some of this stuff. But I'm sure, I learned a ton, and I'm sure our listeners will learn a ton from this too.
Yeah, I think the big message when I think about it is really, because doing this made me think about, why have I stayed in this? Why haven't I just retired and bought a condo, somewhere nice? And really is this curiosity and keeping up with what's going on. Things are changing. And to me, it's exciting to be at that front of where things are, rather be at the front of change and help make the change rather than see what happens as a result. So yeah, that's why I've done it. And that's what I would encourage, SIIM members and the junior people, the young ones who are starting out. Think about that. If this is what you enjoy, that you picked the perfect thing to do.
Stay curious.
Yep.
Stay curious. And thank you again so much for your time.
Sure.
This is extremely inspiring. And I know that now we've got this captured on audio. It's going to be in archives for many more.
That'll be good.
Enjoy. And I can imagine this definitely going to be one of our most popular episodes.
Yeah, like we have Joe Gitlin, an interview I did with him. He tells some interesting stories about the start of DICOM. So
It's also great because, Don just did the Dwyer lecture. So to hear more stories about Sam.
Yeah.
Our generation didn't get to know Sam, but to hear more of these stories and see pictures and things like that, it's also interesting to see again, like how his influence
really
Oh, yeah.
overshadows so much that
Oh, yeah.
we just don't even know about it.
He was the one who first referred to me as small but mighty. And I know some people come up to me who've heard that story and they say, hey, how are you doing? Small but mighty. All right. Well, thanks very much. I appreciate the opportunity to do this.
SIIMcast has been brought to you by the Society of Imaging Informatics and Medicine. Please visit our website at SIIM.org for more information and educational content, including webinars and an archive of prior episodes. Please follow us on Twitter at SIIM_tweets. Thank you to our listeners for your continued support.